Professor Sajid Maqbool. He is a fellow of College of Physicians and Surgeons, Pakistan, Royal College of Physicians, American Academy of Pediatrics. He is Professor Emeritus of University of Child Health Sciences and former Dean of Children's Hospital. He is a teacher of the teachers. His lecture is on the state of neonatal infections in Pakistan. Professor Sajid Maqbool. Sir, please.
Thank you very much. I think one of the hardest things to do is to deliver a talk or try to deliver a talk when the first speaker is Professor Zulfikar Bhutta, a giant, and then to be followed by another giant, Professor Haq. So what am I going to say? Not much. So maybe I can give you simplified Pakistani version of what both of them are trying to say. So let me begin. So what I am planning to do is to talk a little bit about neonatal morbidity and mortality. I'm also going to emphasize the importance of maternal health. We're going to talk about the role of infections, the spectrum as we see it in Pakistan, and the factors that contribute to it. And like I said, there will be quite a bit of an overlap between the first presentation and the one that follows. And lastly, I will talk about some of the remedies or management or prevention. So let me explain this to you. This would be in the context of Pakistan only and not really worldwide in any sense. Now, Pakistan, as you know, is a country of various provinces. The population is distributed somewhat unevenly, and there is a considerable inequity, not only amongst the provinces, but also between the rural and urban areas. And this has always been a tragedy of Pakistan, where access to healthcare has been provided disproportionately. The population base is rather heavy. The pyramid has a very large proportion of people who are under maybe 18 or 19, and this doesn't bode well for the coming generations with the problems multiplying very rapidly. We also have the state of the mother, which affects the neonate quite a bit. The age at first marriage is less than in many countries. They marry at a younger age. They have a high fertility rate. The median age of first birth is also very early. Our birth intervals are short, and a significant number are married somewhat early and therefore deliver the first baby very early when they're themselves not quite out of childhood. And the rate of contraception is abysmally low. So what that means is that the maternal mortality ratio is significant. And although we talk about maybe 140 cumulative rate, we're actually talking about a whole range. And of course, our friend sitting here from Balochistan will recognize that some parts of the country have a very high maternal mortality ratio. Balochistan as high as possibly 298, with the lowest being from General Salman's area, which is Gilgit-Baltistan and also Azad Kashmir. But the average is about 140, still very high. The problem that Professor Bhutta alluded to was the access to healthcare in Pakistan. There are problems that other societies don't face. One is to get a permission to see the doctor. Just a simple fact of being able to get a permission to see a doctor. It may be a matter of finances, they can't afford it, and the distance to health facility, not to forget the transport that may be used. And again, socio-culturally, the mothers may not want to go to the health facility alone. And if you look on the right side, it is worse for those who are younger, it is worse for rural areas, and worse for the poorest, and worse for those who are not educated. So this is the state of affairs of the mothers. And when we look at the postnatal checkups, very low if it is the first 2 days, 64% only. And when we talk about within the first hour, are they seen by somebody who is a qualified health care provider, it is only 41%. So in this sort of a thing, you can also look at it another way, and that is that the level of education is directly proportionate to the age at first marriage. The less educated you are, the younger you're going to get married. So why am I telling you all this? That is that it is intimately linked to morbidity and mortality. And although Pakistan has made strides in under 5 mortality, infant mortality, but look at the neonatal mortality, whether it is 40 or 42 at the present time, the fact remains that we have not made much of a dent in the neonatal mortality in the last so many years. Professor Bhutta alluded to the SDGs, and of course, the third goal is the one pertaining to health. And we in Pakistan have the distinction, I shouldn't be calling it distinction, but we have possibly the highest baseline neonatal mortality rate, which has been mentioned. And he also mentioned that the rate at which we are going, there is no way we're going to meet the SDG goal for reduction of the of the neonatal mortality rate by the year 2030, which is the goal. Now, you can also see some of the other countries who've done much better, but Pakistan joins a few countries that include 2 African countries, and Pakistan still one of the highest neonatal mortality rates. The causes are well known to you: neonatal infections, of which we are deliberating today, birth asphyxia, which is still a problem, and of course, prematurity or low birth weight that Zulfikar just spoke about. So what I'm going to do is leave the topic that is under discussion most of the time, and that is neonatal sepsis, towards the end, and talk about the whole spectrum of infections that we as neonatologists, as practicing pediatricians, as practicing healthcare professionals who are likely to see either in our clinics or in the nurseries that we see. So let me talk about the issue in some detail. And you have to understand that the neonatal infections are related directly to maternal health, as has been alluded by the first speaker, to the hostile environment that I'll talk about in a few minutes. And of course, when a baby is admitted, or is fortunate or unfortunate to be admitted to our nurseries, it is the unnecessary interventions that cause aggravation of the problems further. Of course, you all understand that a neonate has a suboptimal immunity, and I'll briefly mention that because I'm aware that both Professor Huck and the other speakers are going to be talking in greater detail about this. So a newborn who's absolutely healthy, is full term, has had no complications, even with all that advantage that this baby has, is still vulnerable to infection. And you're all familiar about the reasons for this. The reasons obviously are the lack of immunity, whether that be cellular, whether that be humoral. You can get some immune globulin G from the mother. A neonate can, a fetus can generate a response of IgM, but it is not as vigorous, it is not as useful, and it may not be timely, and therefore there is a problem. We also alluded to the skin barrier, which is often invaded by those who take care of the baby, whether it be at home or whether it be the nurses or whether it be the doctors. And this is, of course, even more important when you're dealing with a preterm baby. And also added to this is the immaturity of the GI immunity and the implication of the use of probiotics that you have just heard. So some common infections that practicing pediatricians and neonatologists is likely to see, and this is not an uncommon condition, whether the baby is delivered at home or unfortunately in the nursery, something that looks very simple, and when it is simple, it is treatable just by local washing and local antibiotic ointments. But remember, this may be a precursor of an infection which may occur a few days later. Most of these are staphylococcal, and of course, when they have systemic symptoms such as fever or hypothermia, not feeding well, and and being irritable, you have to understand that this will require a course of antibiotics, which is often intravenous or intramuscular. Conjunctivitis is often another problem. We don't see it as frequently. Fortunately, we don't see the viral infections as commonly, and this has to be always sorted out with the underlying problem with the nasolacrimal duct, and of course can be treated with careful washing, good hygiene, and some antibiotic ointment or drops. This very rarely changes into a systemic infection, but does have the potential when you can get cellulitis and then bacteremia. Omphalitis has been referred to by Professor Bhutta also, is a very, very common condition, and that has to do directly with the poor cord care that we provide, but also where there is a prolonged rupture of membranes in a baby who may be low birth weight or has passed through a mother who has had infection, a delivery that may have taken place in a non-sterile environment, which happens at home. And please understand that just being delivered in a quote unquote healthcare facility does not mean that this is a very sterile or a very clean environment. And of course, improper cord care. Thrush is another common condition, and I see that there'll be a whole session on candidate or fungal infections tomorrow, so I will not sort of dwell into it in greater detail. But this ubiquitous organism is around, possibly transmitted from the mother or the feeding bottles or the nipple. And when it is present in those who are premature or have had birth asphyxia or have come from a mother who has an infection, then it can become systemic, it can become a multi-organ involvement, and of course, add to this the tremendous use of antibiotics that will also lead to candidal infections. Osteomyelitis, something that we don't see very often, and we are sometimes at a loss to diagnose because a neonate presents differently when there is an infection, especially of the bones and joints, and you have to be very, very careful and observant in your physical examination. The hallmark is decreased movement in that particular area. It's invariably the hip. There is some pain only when you move the baby's leg, and if you're lucky, there may be swelling. And of course, if there has been a complicated delivery, again, more common in prematures, and if there's been skin infection or a central venous catheter or a urinary tract infection, there is a greater chance. Now, this infection, of course, requires, since it is caused mostly by staphylococci, but also can be caused by gram-negative infections, requires treatment for a period of 4 to 6 weeks, which is quite a difficult task to do in some of these babies. I know this is something that people don't talk about, but those of us who have seen cases, unfortunately, continue to see them. And this comes from the Clostridium tetany, which is still around. And I would refer you to the maternal and neonatal tetanus elimination, which was started in 1999. And the goal was to get 80% pregnant women at least 2 doses of tetanus toxoid. These days, they're also recommending the Tdap to be one of them, and also recommending that we have 3 rounds of tetanus toxoid containing vaccine in the SIAs, or the supplementary immunization activities. Pakistan, of course, has fallen behind. This should be combined, of course, with good cord care that we spoke about, the use of chlorhexidine. And as you can see, the higher the number of these SIAs, the lower the incidence of neonatal tetanus. Pakistan, unfortunately, is counted amongst the 12 countries that still has neonatal tetanus that has not been eliminated, fortunately. And unless we pay more attention amongst the emphasis that we have on other forms of immunization for other diseases, which obviously are equally important, we will again fall behind. Now, what are the reasons of neonatal tetanus? And largely, it has to do with inadequate knowledge of the tetanus toxoid vaccine itself. Sometimes inadequate information provided by the health workers living in rural areas, which seems to be a big problem for all health-related issues, not being educated, and of course, not knowing where to go, when to get vaccinated, during pregnancy, before pregnancy, after delivery, or when. And of course, we think that it may be inadequately reported, so that the actual incidence of neonatal tetanus may unfortunately be higher than we think. So what are the interventions? One, of course, is the tetanus toxoid vaccination. And like the target that we're going to or hoping to achieve seems to be unreachable, because we're at 69 and we want to achieve 98%. And we also have lagged behind in stillbirth attendance at the present time. And these are Pakistani figures from the latest survey. And of course, there are other areas within the preventive realm that we have fallen behind. Tetanus, I've already spoken about. Clean birth practices, I have alluded to. Exclusive breastfeeding, we are again way behind. We're only at 55%, whereas we want to reach a much higher target. And that is not only early, but sustained breastfeeding, which has, as you have heard, a positive impact on prevention of infection. Clean postnatal practices, which also includes chlorhexidine, application of it, especially those who are delivered at home, or especially those who are premature. And we will also talk about the case management of neonatal sepsis, which has to be standardized, which again, Professor Bhutta referred to. So let me just then talk about a topic that will be hammered in greater detail today and tomorrow, has been discussed somewhat initially by Professor Bhutta, and I know Professor Haq will have much more to say on this, so I will try and limit my remarks about neonatal sepsis, only to say that this is largely a clinical diagnosis, and we still seem to be struggling with the proper definition of neonatal sepsis. It depends on who defines it. Anybody who looks sick in the nursery or in your office has neonatal sepsis, and that is one of our biggest problems. In the lower middle income countries such as ours, we have the habit of making a diagnosis clinically. Of course, we do have to have a high index of suspicion, but we only make it clinically. Laboratory facilities are limited, not only in the rural areas, but also in the cities. And even within the cities, there are very few centers that have the facility to give us antibiotic sensitivity resistance patterns. And therefore, treatment is what is called empirical. It is not standardized. And I will talk about some recommendations about that. We know, second thing that we know is that they're commoner in Pakistan, and this has been mentioned repeatedly, has been shown in studies within Pakistan and from different cities. Thirdly, that the organisms that we see are different. We see a lot of Klebsiella, we see Pseudomonas, we see E. coli, and we see Staphylococcus, if you were to count the majority of them. And these have been shown in studies from different parts of the country, whether it be Bahawalpur, Peshawar, Karachi, Lahore, or other parts of Sindh. We also know that this carries a very high mortality, as was shown by Professor Huck's most recent publication, which was published in the Pakistan Pediatric Journal, and carries a very high mortality, especially when it comes to early onset sepsis rather than late onset sepsis. So it is more common, it is caused by a few organisms that are different compared to other countries, carries a high mortality. And on top of that, we have this difficulty of antibiotic resistance, which is a worldwide phenomenon, but I dare say that this is a bigger problem in our country. A very informal survey of the nurseries within the city of Lahore just 3 to 4 months back showed that between 80 to 90% of all babies admitted in the neonatal units had been given antibiotics for one reason or another. It is sometimes almost impossible to find a baby in the neonatal unit who is not on antibiotics. Just like it is almost impossible to find a delivery that has been delivered normally, vaginally, and all babies almost in the hospitals have been delivered by cesarean sections. To a point where when I see a baby delivered normally, vaginally, I usually ask them, what went wrong? Why is this baby delivered the abnormal way and not the normal way of cesarean section? Oh my God, what is this? Okay, sounds Latin to me. I don't know what happened. What the slide tells you is that the organisms that are common, and the WHO recommendation of the first line antibiotics, which is ampicillin and gentamicin, does not hold true. And therefore, it is a problem because the organisms that we see that I've listed are no longer susceptible to these particular conditions. So, like I said, Professor Huck will talk about this in greater detail. But to summarize, we have no specific agreed definition of neonatal sepsis. It is much commoner. The organisms are as listed. Antibiotics are used not only too frequently, inappropriately, but also for too long. We're in the habit of, once you start an antibiotic, you don't want to let go. It's like the mic, you get hold of the mic and you don't want to let go. It's not only the Maulvis who like the mic, also speakers do too. We have the same problems with antibiotics. Once we start them, we forget to stop them, even if the culture is negative, even if the baby has improved. Antibiotic resistance is high. Like I said, most of the antibiotics that are recommended are not useful anymore, and we have a very high case fatality. And of course, comorbid conditions such as prematurity, birth asphyxia, and other conditions compound the situation. So that is, to summarize, the neonatal sepsis part of infections within Pakistan. So we do have a high neonatal mortality, no doubt about it, but our contention is that largely this is preventable. Obviously, if you can prevent prematurity, if you can prevent low birth weight, if you can prevent birth asphyxia, and if you can obviously then prevent infections through preventive measures, we can bring the neonatal mortality down. So what are the remedies, or what is the preventive care? Something that we all forget to do every single day when we get to the nursery or handle a baby, and that is hand washing. So if there was one important message that we must convey to all our colleagues, is hand washing, hand washing, and hand washing. It must be done. Strict hygienic practices are very important. In the nurseries, we need to cohort patients who are infected. We need to use disposable equipment. That is something that I don't have to emphasize. We need to isolate patients, and we have to control antibiotic use. We're using far too many. I'm often confronted by a list of antibiotics, sometimes the nature of which I don't understand. I don't even know the kind of antibiotics that are being used for newborns. Of course, the most important aspect is good infection control. So what can we do infection control in the neonatal unit? We need to start from the labor room, clean surfaces, clean perineum, cord care, very, very important, as you've just heard, cutting instruments, whether that be in the nursery, in the delivery room, or at home. We do not pay attention when we set up nurseries. We don't pay attention to the requirements of a neonatal unit or a nursery unit. We don't pay attention to how much distance between one cot to the other. We don't pay attention to the kind of washing facilities. We don't pay attention to the kind of ventilation that is required. We do not have a uniform policy about the nurses. And I'm not talking about some of the well-developed centers like the AKU, but I'm talking about most others. So it's very, very uncomfortable to see nurses with long nails, wearing jewelry, not washing hands, and handling babies. We need to limit the use of cell phones. We need to reduce the number of visitors. And of course, cleaning and maintaining the cleaning routine must be not only done monthly, but has to be done daily, every single day. There should be a routine, and of course, weekly and monthly. And then the infection control with a better nurse to patient ratio, cord and skin care, and the best practices, of course, that we ignore all the time, that Professor Bhutta just spoke about, is the impact of early and sustained breastfeeding and the kangaroo mother care. And I see in the audience there are some who are experts at this, who've done a marvelous job of this. Professor Rubina left, but Professor Tayyiba is here, whose unit carries on, one of the units that carries on this wonderful work of kangaroo mother care. We must have an infection control committee in each hospital or each nursery, and we must rationalize the use of antibiotics if we have to move forward. So I leave you with the following reminders. One, that the neonatal mortality is very high, as is the maternal mortality ratio. Infections contribute significantly to this morbidity and mortality. These infections are wide-ranging and commoner compared to other countries. Poor maternal health, suboptimal antenatal care, inadequate delivery practices, and substandard postnatal care all contribute to the increased infections. Anticipatory guidance, preventive measures, appropriate supervision, and agreed to recommended practices are very, very important. So the way to go will be to take stock for this conference, that is to look at the existing situation. And I am sincerely hoping that we'll come up with very, very useful recommendations after deliberations, because I'm sure all of you are here not to just to listen to these giants, but also to see how we can move forward. We have to pool resources, and I am a big proponent of a perinatal setup, which includes obstetricians and neonatologists to work together. We must establish guidelines and adhere to them, which includes infection control and antibiotics, and of course, strict adherence to this, and looking at these from time to time in a timely audit so that we can move forward. With those remarks, I thank you very much for your attention. Thank you.